Usually when we think about how the human body breaks down or malfunctions, we default to this very biochemical mindset.
Right, yeah, like hormones falling out of balance or maybe a virus invading a cell.
Exactly, or
Right.
genetics just dealing a tough hand. But sometimes when you're trying to understand a really stubborn health issue, you have to kind of put down the biology textbook.
And pick up a physics textbook.
Yeah, you have to look at the body not just as like a collection of cells, but as this interconnected mechanical system of pumps and pipes and pressures.
Which is such a fascinating way to look at it.
It really is. And today, for you listening, we're doing a deep dive into a stack of incredibly fascinating research. We've got the PRIDE trial, some remarkable bariatric surgery outcome studies, urodynamic research, and even massive epidemiological data sets like the NAA-knee study.
Which is a huge amount of data.
Massive. And we're
Yeah.
using all these sources to tackle a highly specific, but honestly surprisingly common question. Can significant weight loss reduce your internal intra-abdominal pressure enough to actually resolve mild stress urinary incontinence?
And exploring that, it requires a complete reframing of how this condition is typically viewed by most people.
Right.
Because for a long time, stress urinary incontinence, or SUI, has been treated as this inevitable, almost fatalistic part of aging.
Or just, the permanent cost of having a baby.
Exactly. So people suffer in silence, kind of assuming their body is just permanently broken. But the clinical sources we're looking at today, they paint a very different picture.
Yeah, they reframe it entirely as a problem of fluid dynamics, internal atmospheric pressure, and, well, what we call a reversible mechanical load.
Right. It's an engineering problem.
So to understand how losing weight could possibly cure a bladder issue, we first have to map out the exact mechanics of what goes wrong in the first place.
Sure.
Because when we talk about SUI, we're not talking about that sudden uncontrollable urge to go to the bathroom. This isn't a hyperactive bladder where the muscle is just spasming on its own.
Right. No, that would be urge urinary incontinence. That involves involuntary contractions of the detrusor muscle.
The detrusor muscle.
Yeah, that's the smooth muscle that makes up the wall of the bladder itself. SUI operates on a completely different physiological mechanism.
Yeah, SUI is specifically the involuntary leakage of urine during physical exertion. So we're talking about coughing, sneezing, laughing, jumping, or even just lifting something heavy.
Exactly.
And reading through these sources, I had this analogy pop into my head for you guys listening. Think of the bladder and the urethra like a juice box with a flexible straw.
I love that analogy.
Right, because stress urinary incontinence happens when the pressure squeezing the outside of the juice box is simply stronger than the pinch holding the straw shut. The fluid has literally nowhere to go but up and out.
The clinical terminology actually mirrors your juice box perfectly.
Oh, really?
Yeah, so in urodynamic studies, which are these tests that assess how well the bladder and sphincter hold and release urine, leakage is observed the exact moment the intra-abdominal pressure suddenly exceeds the maximal closure pressure of the urethra.
Okay, so the squeeze beats the pinch.
Exactly. Because the bladder sits inside the abdomen, any pressure in the belly transfers directly to the bladder wall. The system just gets mechanically overwhelmed.
Now.
The pinch on the straw simply cannot withstand the immense sudden squeeze on the box. And what's wild is this happens entirely without any involuntary muscle contractions of the bladder itself.
So the bladder isn't doing anything wrong.
Not at all. The detrusor muscle remains perfectly quiet. The external force dictates the failure.
That is so wild. And we really shouldn't understate how massive of an issue this is either. Like, according to the epidemiological data we looked at, SUI is the most common form of urinary incontinence by far.
Well, absolutely.
It affects a huge portion of the global female population. Millions upon millions of women have their quality of life, their mental health, and their physical activity severely restricted because of this specific mechanical failure.
The burden is just tremendous. It dictates what clothes that people wear, whether they feel comfortable socializing, and crucially, whether they feel safe engaging in physical exercise.
Which we'll definitely get back to later.
Right. But understand that the underlying physics isn't just an academic exercise,
Yeah.
It's the fundamental first step to reclaiming agency over the body.
Totally. So if a sneeze or a laugh is just this temporary spike that breaches the system, the real culprit has to be whatever is keeping the baseline pressure so dangerously high the rest of the time.
Bingo.
And the data points an immediate finger at central weight. The statistics in these studies are startling. For every 5-unit increase in body mass index, there is a 10% increased odds of developing SUI.
It scales right up.
Yeah, and when you look at women with a BMI over 40, The prevalence of SUI reaches nearly 70%. That is a staggering majority.
It really is.
But looking at this structurally, I kept wondering, is this just gravity? Like, is it literally just the physical dead weight of abdominal fat pushing down on the bladder from above? Or is there an actual internal atmospheric change happening inside the body cavity?
It is a literal, measurable increase in internal atmospheric pressure.
Wow.
Yeah, in the medical literature, this is tracked as intra-abdominal pressure, or IAP. Now, obviously, it is inherently difficult to directly measure the ambient pressure floating around between your internal organs.
Right, you can't just stick a barometer in there easily.
Exactly. So clinicians often use urinary bladder pressure as a reliable proxy. And when they measure this, they find that bladder pressure directly correlates with sagittal abdominal diameter.
Sagittal abdominal diameter, so that's basically the physical depth of the belly from front to back, right?
Exactly. The deeper the abdomen, the higher the baseline pressure inside the abdominal cavity.
So it's not just a heavy weight sitting on top of the organs. It's a pressurized environment squeezing from all 360 degrees.
Imagine filling a balloon with water and then submerging that balloon inside a sealed, pressurized tank.
Okay, I'm picturing it.
The pressure of the tank constantly, uniformly squeezes the balloon from all sides.
Yeah.
In the human body, central adiposity, so visceral belly fat, acts to increase the pressure of that internal tank.
That is a crucial distinction.
It is, because it's not just heavyweight. This chronic ambient pressure acts as a constant load on the continence mechanism.
Like 2047.
Exactly. It isn't just happening when you cough. It is a relentless background stress on the pelvic floor muscles, the fascia, the ligaments, and the urethra.
But see, this is what tripped me up in the research. Establishing that this high background pressure exists makes total sense. But chronic pressure doesn't just squeeze things, it stretches them, right? It wears them down over time.
It does.
So if this chronic pressure stretches the pelvic floor muscles, and according to some of these papers, even damages the pudendal nerve over time through chronic tension, wouldn't that mean the damage is permanent? Like if you stretch a rubber band too far for too long, it doesn't just snap back to its original shape. So how could merely losing weight fix a nerve or a muscle group that has been physically stretched out and damaged for years?
That is such a good question, and you're touching on one of the most critical nuances in this entire data set.
Okay.
Because in some specific cases, yes, there is permanent structural failure. Severe nerve damage or massive tissue tearing, which is often associated with complex or multiple vaginal deliveries, for instance.
Right, things like that.
Yeah, those might cross a point of no return where a surgical intervention, like a mid-urethral sling, becomes necessary to artificially support the urethra.
Okay, that makes sense.
But much of the dysfunction we see in overweight and obese patients is not about absolute permanent failure. It is about thresholds.
Meaning the system is still functional, but it's just operating way too close to its breaking point.
Exactly. Think of a suspension bridge with a strict weight limit. Let's say the bridge can safely hold 10,000 pounds before it collapses.
Okay.
Now, imagine a scenario where the continuous flow of heavy commercial trucks means there is constantly 9,900 pounds on that bridge.
Yikes. So it's pretty stressed out.
Very. The structure is groaning, the cables are stretched taut, it is hovering right on the edge of structural failure. Now, a single compact car drives onto the bridge, pushing the total weight to 10,100 pounds.
And the bridge begins to buckle.
Right. But the compact car didn't inherently break the bridge, the background traffic did. The car was just the tiny acute spike that pushed it over the maximum threshold.
Oh, that makes so much sense. And the urodynamic studies in the sources really illustrate this. Like, they found that obese women have a significantly higher baseline abdominal pressure at their maximum systometric capacity.
Yes, and just to clarify, that's the specific point during a urodynamic test where the bladder is filled with sterile fluid and the patient reports feeling completely full.
Okay.
At that exact moment, their baseline pressure, the heavy trucks on the bridge, is already incredibly high. They're constantly living right on the edge of their incontinence threshold.
So their internal pinch, going back to the juice box, might actually still be relatively healthy. Like the nerve might not be entirely broken. The muscle might still have some decent tone.
Exactly.
But they just can't overcome the fact that the background squeeze on the box is permanently cranked up to a 9 out of 10.
The continence mechanism is certainly compromised by the strain, sure, but it only fails during a cough or a sneeze because the baseline demand is simply too high. The margin for error is completely gone.
Wow. Which brings us to the million-dollar question for you listening right now. If a person clears the heavy trucks off the bridge, does the internal pressure actually drop enough to stop the leaking?
That's the real question.
Right, or is the bridge just too worn out from years of heavy traffic to hold even normal weight? Well, looking at the PRIDE trial, which is the program to reduce incontinence by diet and exercise, the intervention is astonishingly effective, and the numbers aren't what you might expect.
They really aren't.
Like, I was looking for massive life-altering weight loss, but the threshold for relief is actually quite low.
The PRIDE trial is a landmark piece of research precisely because it demonstrates how achievable this mechanical reset is.
Yeah.
They took overweight and obese women experiencing frequent urinary incontinence and put them in an intensive 6-month behavioral weight loss program.
And this wasn't just, a casual suggestion to eat less.
No. It involved structured behavioral modification, weekly group sessions, specific caloric restriction goals, and prescribed physical activity.
Very thorough.
Yeah, and they compared this intervention group to a control group that merely received structured education about incontinence. Over 6 months, the intervention group lost an average of 8% of their body weight.
And to put that in perspective, for the average participant in that specific study, an 8% reduction equated to about 7.8 kilograms, or roughly 17 pounds.
Right.
So we aren't talking about extreme makeovers or like becoming a fitness model. We are talking about a modest, highly realistic weight loss target.
And that modest 8% weight loss resulted in a massive 47% decrease in weekly incontinence episodes.
That's incredible. Nearly a 50% reduction in physical leakage simply from dropping 17 pounds.
Meanwhile, the control group, relying on education alone, only saw a 28% reduction. The study also highlighted that a significantly higher proportion of the women who actively lost weight achieved a 70% or greater reduction in all urinary incontinence episodes.
It's just so definitive. And there was another study in the stack that pushed this dose-response relationship even further.
Oh, the liquid diet one.
Yeah. They used a strict 3-month liquid diet program to induce faster, more significant weight loss. Those women lost a median of 16 kilograms, so around 35 pounds.
And the results were even stronger.
Yeah. The reduction in weekly incontinence episodes jumped to 60%. It's a direct mechanical correlation. Remove more of the heavy trucks, and the bridge regains even more of its structural stability.
And we aren't just relying on patients self-reporting their symptoms at home either.
Right.
The underlying physics are changing in real time, and we can watch it happen through bariatric surgery outcome studies. When researchers perform full urodynamic testing on women before and after massive surgically induced weight loss, the data on the monitors objectively shifts.
So let's actually visualize what is happening on those monitors. They are threading a catheter into the bladder, filling it, and measuring the exact millimeter of mercury where the system fails. What actually changes after the weight is gone?
They observe a significant decrease in both the initial and maximum capacity intravesical pressure.
Meaning the ambient pressure inside the resting bladder demonstrably drops.
Exactly. Concurrently, they measure an increase in something called the Valsalva leak point pressure.
Okay, the Valsalva maneuver, that's when you bear down, right? Like, it's the physical action of trying to exhale forcefully while holding your nose and mouth shut, or bracing your core to lift a heavy box.
Right. It's the clinical method for artificially spiking your intra-abdominal pressure in a controlled setting. So the Valsalva leak point pressure is the exact quantifiable amount of force required to push urine past the sphincter.
Got it.
After weight loss, that leak point pressure goes up.
So the system can suddenly withstand a much higher pressure spike before it fails.
Exactly, because the background pressure, that reversible load, has been physically removed from the cavity.
The juice box is no longer being squeezed by default, so the straw can easily hold back a sudden jolt. The system basically resets itself.
It really does.
It's honestly incredible how mechanical it is. It really takes the mystery and, frankly, a lot of the stigma out of the condition. It's just an engineering equation that has temporarily fallen out of balance.
I completely agree. It moves the condition from inevitable to modifiable, which is profoundly empowering for the patient.
Definitely. Now, the final piece of the puzzle is how to lose that weight safely and effectively. And this brings up a fascinating nuance in the NAGS study.
Yes.
NADNES looks at huge swaths of epidemiological population data, and they found it's not just about your total body fat percentage, it's about fat distribution.
Yes.
The data specifically zeroes in on the android to gynoid ratio, or the EG ratio.
Right, so android fat distribution is what is commonly referred to as an apple shape, where adipose tissue is stored centrally, tightly packed around the abdomen and visceral organs.
And gynoid.
Gynoid distribution represents the pear shape,
Yeah.
where fat is stored lower on the body, around the hips, buttocks, and thighs.
So a high AG ratio, being apple-shaped, is a significantly stronger predictor for stress urinary incontinence, which makes sense mechanically. Fat stored on the thighs isn't putting internal pressure on the bladder, but central, visceral fat in the abdomen is. The proximity of the weight dictates the physical pressure on the pelvic floor.
Absolutely.
But this creates a paradox that seems entirely counterintuitive to me. If SUI is triggered by physical exertion and it's driven by high intra-abdominal pressure, shouldn't vigorous exercise actually make the incontinence worse?
That's a very logical question.
Like if someone goes for a run or does a high-intensity interval workout, they are bouncing around, bearing down, and constantly spiking their abdominal pressure. Wouldn't the standard medical prescription to go exercise to lose weight just cause more leaking, more frustration, and ultimately damage the system further?
It really seems contradictory on its face. But the resolution to the paradox lies in understanding the dual nature of exercise.
Yeah.
You have to separate the acute, immediate effects from the chronic, long-term physiological adaptations.
Okay, so we have to separate the 45-minute workout from the year-long habit.
Precisely. Acutely, during the physical act of vigorous activity, you absolutely do temporarily spike your intra-abdominal pressure.
Right.
And the data heavily reflects this. Competitive female athletes, particularly gymnasts, trampolinists, and CrossFitters, they often experience high rates of SUI during their sport because they are generating immense mechanical forces.
So while they are actively doing jumping jacks or tumbling, the bridge is placed under maximum immediate stress.
Chronically, however, the picture changes entirely. Habitual, vigorous exercise has a profoundly different structural effect on the body. First off, it actively strengthens the pelvic floor muscles.
Oh, interesting.
Yeah, even if a person isn't doing targeted, isolated Kegel exercises, systemic vigorous movement forces the entire pelvic floor to engage, adapt, and build tone to stabilize the core during movement. It builds neuromuscular resilience.
Oh, I see. So you are reinforcing the cables of the bridge with stronger steel.
Exactly. And beyond reinforcing the structure, chronic vigorous exercise actively modulates the fat distribution we just discussed. It specifically targets and shrinks the waist circumference, lowering the android to gynoid ratio.
Okay, so over the long term, exercise directly removes the central adiposity.
Right, which lowers the chronic baseline intra-abdominal pressure that was setting the stage for failure in the first place.
Wow. So the very activity that spikes the pressure in the short term is the most effective tool for lowering the baseline pressure in the long term while simultaneously strengthening the pinch on the straw.
Exactly. It's a net positive structural adaptation, even if it causes a little mechanical leakage in the moment.
That makes perfect sense. And it perfectly highlights why behavioral programs like the Pride Trial always combine diet and exercise. You attack the high pressure from the outside by shrinking the abdomen through caloric deficit, and you fortify the pelvic floor from the inside by building muscle tone through systemic exercise.
It is a two-pronged attack on a localized physics problem. The body demonstrates an immense capacity to restore its own mechanical balance, provided you give it the structural support to do so, and remove the excessive ambient load.
That is just so cool. Let's bring this all together for you, the listener. If you are tracking with the data, the major shift in perspective here is that mild stress urinary incontinence in overweight individuals shouldn't automatically be viewed as a permanent, irreversible structural failure.
Right.
The rubber band isn't necessarily snapped. In an overwhelming number of cases, it is simply a direct mechanical result of chronically elevated intra-abdominal pressure.
The internal tank is just overpressurized.
The heavy trucks are parked on the bridge, safely reducing that central weight, even by a highly achievable amount, like 8%, effectively removes that mechanical load.
The internal pressure drops, the pelvic floor muscles recover their tension, and the body's natural continence mechanisms are given the space to function normally again.
It is quite literally a mechanical cure for a mechanical problem. But as we wrap up this deep dive into the physics of the abdomen, there is a lingering detail in the sources regarding what else this pressure is doing.
Oh, yes.
Because if this localized pressure in the belly is powerful enough to overcome the urinary sphincter, it has to be pushing against everything else in the cavity as well, right?
Well, it absolutely is. And the implications of that elevated baseline pressure are truly profound. You have to remember, the abdomen is a sealed cavity. It doesn't isolate its force.
Right.
The sources briefly note that this exact same chronically elevated intra-abdominal pressure is heavily linked to a host of other seemingly unrelated obesity comorbidities.
Like what?
Well, consider gastroesophageal reflux disease, or
Mm-hmm.
GEFU. If the pressure in the abdomen is constantly high, it pushes aggressively up against the stomach, eventually forcing stomach acid past the lower esophageal sphincter.
Oh my gosh, it is the exact same mechanical override as SUI, simply pushing up toward the throat instead of down toward the pelvic floor.
Exactly. And it doesn't stop there. That upward pressure forces its way against the diaphragm, physically restricting lung expansion, which is a massive mechanical contributor to obesity, hypoventilation syndrome, and sleep apnea.
Wow.
It pushes laterally against the renal veins, potentially contributing to systemic hypertension. It compresses the major vessels in the legs, leading to chronic venous stasis and poor circulation in the lower extremities.
That is incredible. Everything is connected.
It really forces us to look at the broader medical landscape and ask a pretty provocative question.
Which is?
How many other stubborn chronic health conditions like acid reflux, sleep apnea, or high blood pressure are we currently treating with lifelong medications and complex therapies when they might secretly just be localized physics and pressure problems waiting for a simple mechanical cure?